My name is Veronica Montanero, and I am going to talk about Ribavirin for chronic hepatitis A virus infection in transplant reset and immunotherapy in renal cell carcinoma. First definition. Hepatitis A is a liver disease caused by infection with a virus known as hepatitis A virus. The virus has a lead for different types: genotype 1, 2, 3, and 4. Genotype 1 and 2 have been found only in the human. Genotype 3 and 4 circulate in several animals without causing any disease and occasionally infection human. The second, in monotherapy in renal cell carcinoma. Definition. Renal cell carcinoma is the most prevalent kind cancer with nearly 63,919 cases diagnostic and 14,400 deaths in 2017. Approximately 25 and 13% of cases are metastatic at diagnostic, and 20 and 13% of patients with blood sugar measure for a local RCC show metastasis.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more videos, subscribe to our channel.
Application in medicine. The hepatitis A virus is transmitted mainly through the fecal-oral route down to the fecal contamination of drinking water. This rule accounts for a very large proportion of clinical cases with the disease. The risk factor for hepatitis A are relaxed to poor sanitation, allowing the virus exciting in the faces of infected people to risk drinking water supplies. Immunotherapy in renal cell carcinoma. Application in medicine. Immunotherapy is definitely as exclusive cancer by activity the autoimmune response against the tumor rather than by attacking the tumor directly. Immunotherapy can induce long-lasting anti-cancer response owing the generation of anti-specific immune memory, either through memory T cell or antibodies. Several crucial sets are needed to mount and initiate effective immune response against tumor.
So in moving forward, clearly, almost for the last decade, we've successfully, as Danny pointed out, extended progression-free survival, more than doubled, sometimes tripled overall survival. It's been an absolutely dramatic time for most kidney cancer patients. But having said that, where we have fallen short is that chronic therapy is required. Coming off therapy, disease progresses. Oral agents are still associated with significant, potentially life-changing side effects that change how people do. And we need to be looking for new approaches. And at this past ASCO and throughout our literature, it's very clear that we're revisiting, Jan, the role of immune-based therapy. For those of us that have given immune-based therapy for years, one recognizes that in our practices, if you ask the question, what's the most likely therapy a person received for a period of time and then had an unmaintained remission for years or decades, it's IL-2. And yes, IL-2 is difficult to give, and yes, IL-2 doesn't work in most people, but it does tell us something about biology. So the question, Jan, is are we revisiting the role of immune therapy in kidney cancer, and if so, how? And are we doing it the right way? Did we learn the right lessons from the first experience? Are we applying it in the second experience? And are the endpoints, the biomarkers that we're looking for in the patient populations, the right populations? That's a lot on your plate, but take a stab at it.
Thank you. Yes, immunotherapy is having a resurgence of interest, no question about it. Yesterday morning we actually had a Society of Immunotherapy of Cancer symposium to talk about different approaches. And I will talk to your specific question, which is about the new understanding of taking the brake off the immune system with checkpoint inhibitors. But I wanted to just mention one point that was made, which is still underexplored and needs further evaluation, which is the combination of stereotactic radiation with immunotherapy to get an abscopal effect on tumor. And that has not been well explored in humans, but very well documented in animals. So that's another direction that immunotherapy is going.
So let's just be clear so the audience understands. So by an abscopal effect, you mean that giving local
Hello, I am Johan Neits. I am a professor of virology at the University of Leuven in Belgium.
I am Yannick de Bing. I'm a pharmacist and a third-year PhD student in Johan's lab.
We will present our recent paper in gastroenterology, which is entitled A Mutation in Hepatitis E virus RNA polymerase promotes its replication and associates with failure of Ribavirin treatment in recipients of organ transplant. The study is a collaboration with the group of Professor Heiner Wedemeyer at the University Hospital in Hanover, Germany. 15 solid organ transplant patients with chronic hepatitis E were treated with Ribavirin. All patients cleared the virus except 2 who were non-responders. The first patient received 1 course of
Pros and cons. In rare case, a con hepatitis E can be served and result in fulminant hepatitis. These patients are at risk of death. Fulmination hepatitis occurs more frequently when hepatitis A occurs during pregnancy. Immunotherapy in renal cell prostate. Advantage in gender and biology discovery that can be successful strategies to benefit patients. The development of new pharmacies adjunction. Cons. Risk factors for renal cell carcinoma includes smoking, obesity, and hypertension, as well as arthritis disease associated with say risk disease. Prognosis is closely related to risk disease.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching.
And I think it's important to first redefine hepatitis E and its risk. When hepatitis E was discovered, it was thought to be a hepatitis A-like disease, fecally orally transmitted, present mostly in developing countries with poor sanitation systems, poor water purification systems. And indeed, epidemic outbreaks in developing countries still occur and are quite common. We see them in the setting of refugee camps. There were major outbreaks in Chad during this past year. But there is another form of hepatitis E. That hepatitis E is a zoonotic form of Hep E, which is very poorly recognized and occurs or appears to be a huge and important disease that is under-recognized in developed and Western countries as well as other parts of the world. This disease is spread in animal populations and is thought to be acquired when humans come in contact with animals or eat animal products that lead to infection. So in fact, most people don't realize that approximately 10 to 15% of the US population, with a highest prevalence in the Midwest of the United States, has been infected with hepatitis E, primarily acquired through contact with swine, and perhaps some percentage acquired through eating meat or handling deer in the process of hunting and then consuming the venison. So hepatitis E, various strains of Hep E, are ubiquitous in the animal world. And transmission from one species to another is actually very common as one moves up the food chain. In fact, bears have clearly been shown to be infected with rat hepatitis E, presumably because they eat rats. The group of patients at highest risk for zoonotic acquired hepatitis E infection, both acute infection and actually in many cases progressing to chronic hepatitis E, are immunosuppressed patients, including those that have received liver solid organ transplants and are on lifelong immunosuppression, because those patients not only get hepatitis E, but rather than having a mild illness or an unrecognized illness, they get an illness and then they develop a chronic disease state. They do not clear the virus, leading to progressive injury in their liver. And this is well recognized. The recent report of spread of a rat virus to humans in a liver transplant recipient doesn't surprise me at all. I think the key question that has not been asked is, did this person consume rats? So I think we need to learn more about this case. I also think we need to move away from thinking about hepatitis E as an epidemic waterborne disease, and especially in Western countries, think about it as a zoonotic, animal-associated and acquired disease process.
Usual applies in Ecuador. Every year there are estimated 20 million hepatitis E virus infection worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis A virus. In Ecuador, renal cell carcinoma represents 2.5% in the male population, while in the woman it represents 0.9%. Incidence of renal cancer is 3.4%, mortality 2.4%, and prevalence to 5 years of 3.9%.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help.
And then, conclusion. In conclusion, Ribavirin as monotherapy may be effective in treating chronic hepatitis A virus infection. A 3-month course seems to be inappropriate during for this therapy. Though a long therapy can be given to heavily immunosuppressed patients and those who still have virus 1 month after the initiation of therapy. In conclusion, immunotherapy in renal cell carcinoma is the poor prognosis of advanced renal cell carcinoma demands are aggressive risks for new therapy at this end stage. Already VHL proteins play so as through involving VEGF and TGF are beginning exploring therapy and adjust affecting this therapy be way more effective when used in combination. And finally, watch the video and my social media.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HIV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently, or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.
My social media